Dear colleagues, today I am presenting a very rare and particular case of which only a few instances have been described in the literature. The patient came to our clinic for a second trimester screening, and during the evaluation of the fetal brain, an abnormality in the posterior cranial fossa immediately became apparent. In fact, you can observe from these transverse scans of the fetal skull how the cisterna magna appears. In some planes it appears larger and part of the cerebellum does not look homogeneous. We can clearly see from these images that one hemisphere, the right one, which is at the top in the image, appears morphologically intact. In the vermian region, however, in some transverse planes, an area of decreased signal appears. And we can see that the left hemisphere, which is the one at the bottom, is poorly represented with a clear deficit of tissue. Therefore, the diagnostic suspicion raised was that of an extremely rare condition called unilateral cerebellar hypoplasia, meaning a reduction in volume of only one hemisphere. Cerebellar, which more frequently, as in this case, is the left side with variable involvement of the foliation, the vermis, and the remaining parenchyma. It is such a rare condition that it is not possible to estimate a definitive incidence, and its cause can be either acquired, as in most cases, resulting from ischemic or hemorrhagic lesions, or from malformations caused by perfusion abnormalities. Cerebellar causes can be related to alcohol consumption, congenital infections, mainly from cytomegalovirus, maternal diabetes, or thrombophilia. Other causes, more rarely, can be syndromic or genetic conditions such as File syndrome or sporadic conditions. A brief mention of Feel syndrome: it is a sporadic neurocutaneous vascular syndrome for which no gene has been identified. It is known for vascular, encephalic, and cutaneous anomalies, alterations of the posterior cranial fossa, and most frequently, hypoplasia. Cerebellar hypoplasia, heart defects, and ocular abnormalities are also present. We perform several scans of the posterior cranial fossa in order to better classify the tissue defect and to quantify it for prognostic evaluation purposes as well. And as you can see, in some planes, the left cerebellar hemisphere appears to be compressed by an anechoic formation with regular, well-defined margins, which seemed attributable to an arachnoid cyst with a maximum size of 8.4 millimeters. Therefore, a thorough study of the remaining fetal brain parenchyma was subsequently performed, and all the other anatomy appeared normal. In fact, you have observed the cavum of the septum pellucidum, the insula, the thalami, the corpus callosum, as well as the vascular anatomy, in order to also rule out any possible malformations of a vascular nature. The fetal spine also appeared normal in all its sections. From a diagnostic point of view, in the case of unilateral cerebellar hypoplasia, prenatal ultrasound allows you to detect hemispheric asymmetry, as in this case, and a reduction in the transcerebellar diameter. Additional information can then be obtained through fetal brain magnetic resonance imaging, or MRI, which allows for the careful assessment of any volume loss, cerebellar foliation patterns, the degree of involvement of the vermis and the brainstem, as well as any possible signs of hemorrhagic or ischemic events. Furthermore, MRI also allows for a better differential diagnosis with global cerebellar hypoplasia and cerebellar hypoplasia itself, in which the brainstem is also involved. The prognosis is difficult to determine, but the main prognostic factor depends above all on the involvement of the vermis, which, if not affected, almost always leads to a favorable prognosis, with almost normal cognitive development. However, when the vermian portion is involved, various types of developmental disorders appear, including hypertonia, ataxia, oculomotor disturbances, epileptic seizures, and learning difficulties. For prognostic purposes, we have therefore tried to determine the degree of involvement of the vermian portion, which appears visible in these scans, even if it is likely rotated or hypoplastic, considering the fact that in some planes the cisterna magna appears larger. In fact, we also tried to make use of sagittal scans in which the vermis appeared, as you can see here, to be visible. Therefore, its area and circumference were evaluated. Furthermore, the 3D technique was also used in order to better highlight this structure. Therefore, the patient was strongly advised to undergo a detailed fetal brain MRI, which then confirmed the hypoplasia. The left cerebellar hemisphere with a present but small vermis, thus hypoplastic, and in the absence of what could appear to be vascular signs. These are the MRI images. Here, in these scans, you can see the right cerebellar hemisphere at the top and the left one, which is dysmorphic at the bottom. Then these are the sagittal images which indeed confirm the presence of the cerebellar vermis. The genetic counseling that the patient underwent confirmed that this is usually a condition of classic, that is, vascular origin, but that a possible genetic origin of the defect could not be ruled out. Although in the few cases described in the literature there were no correlations with recognized genetic conditions, it was therefore recommended to proceed with an invasive prenatal diagnosis. The patient also underwent a neurological consultation which confirmed the high risk of neurodevelopmental deficits after birth. This concerns both motor and cognitive abilities. Below, I have included some references to articles that are available in the scientific literature regarding the few cases that have been described, in case you would like to read them for further information. And as always, thank you for your attention.